Absolutely amazing. I never had culture before.
Oh, yeah.
It is. I actually turned the cell phone off. It was great. You know, to go out to eat in a restaurant and I can yeah, isn't it? That is amazingly wonderful.
I would have to do this. They would ask me if it would be okay. I'm like, it's fine. Remember that?
And Jamie said, they were like, well, work part-time and you're fucking like, I'll do 2 weeks for $100. I'm happy to be out of the program. It's just like, problems.
Yeah.
That's been great.
I'm like, I'll never do it again. It's like, you get tired of what you used to do. I'm like, how did I handle this before? Yeah.
So yeah, that part is like,
never go back. You can never go back.
No.
Back out. Always fine. Unless we need to catch it. After that, I'm always fine. Next is time to share calls.
I don't know.
You know what I'm saying? You do the breast there, just splits out. You know, they don't have all the time. No, he's on cold terms.
He removed all those carpets.
Oh, there we go. No, but he's not taking out.
Oh, no, you're doing okay.
Yeah, he's not taking out fully saturated. But I was in 43. We'd be on this cold. It's true.
Yeah, we always start a little late.
Yeah.
Okay.
Yeah. I'm just.
Yeah. I've seen him in ages. Hey, how have you been? What about at the academy meeting? I was there. Did you see me? No. Did you see me? No. So I was at the meeting. I went there on Thursday and I stayed with the rest. Yeah. No. And I was everywhere. Yeah, you know, Dr. Beltrán is senior. Yeah. And all that. Yeah. He didn't even tell me. So I know that. You did? Oh, yeah. I spoke to him.
Like what Beltrán.
And his was there. Tell me. I know. But I didn't know. I mean, he told me when I got there. He didn't tell me. He should have warned me. It's so great to meet it. No, it's changing. The whole.
Like before.
I don't know. You know.
Alex is one of our. Right.
Yeah. I think there's kind of a crossroads there. I think the best solution may be to have 2 meetings, one more clinical and one more.
I guess they were.
No, I know. But this academy is moving more towards clinical stuff.
They were
A little bit. New
right. Mystery reveal. Say something about this.
I think Monday will be the last day.
In that room.
She calls me if I'm away. Okay, so you know.
Right. Like, it was really good. Right. Sitting down with you frequently enough. If you're not doing it.
Right. Not
yeah. So I was like, all right. There's not a microphone. There is no microphone. But does it matter?
How much it was making and we added it all up as one guy. Yeah.
Right. So basically, recording your vocal and then the slide. So like that, I think the post number. I mean, you just I kind of stand up and slide a little bit or I think the partner, you know what than anybody else. They want to learn from you about this.
It is scalable. Your scalable question. GE
The popular guys today.
I don't know. Yeah. Maybe. Everyone wants to start grabbing his feet and get started.
Okay, go in. You want to sit there all well, Snip in 1943, 44. Grandfather position. But I think Jane is not there.
So this morning we have Dr. Susie Cutler from Alkisco Medical Group, who's going to help present a very nice evidence-based approach to tongue tie / lip tie, which is of heavy debate here in our department meetings almost on a monthly basis. So as someone who kind of would like to put some of that debate to rest so that we can move forward in our department meetings, I thought that it would be a great opportunity to utilize a local, expert in this topic to help educate us and walk us through, what evidence exists for or against this problem and the treatment of it. So, take it easy.
Yeah. So,
would that be better?
Yeah, that's good. Yeah, that's good. Just a little personal background. My personal interest in breastfeeding kind of heightened in 2007. I went through every breastfeeding problem in the book with my first child, and really taught me a lot about the experience and education in breastfeeding, but also I think it was maybe higher power's way of making me more empathic to my patients who were going through breastfeeding problems. And in 2011, at an AAP conference, I had an opportunity to meet Dr. Diana Mayer, who's a pediatrician and a certified lactation consultant, who's one of the leading experts in this area, who gave a talk on Ankyloglossia and a workshop on frenotomy. So frenotomy or cutting tongue ties. So I went to the training and have been able to make that a part of my practice when appropriate. And financial disclosures. So I'm hoping that we will be able to help to provide you with the tools and strategies that I've acquired in terms of identifying tongue ties and when it might be clinically significant. We'll touch on historical trends, define ankyloglossia, the potential complications of ankyloglossia, how to assess function, and the frenotomy procedure itself. And if anybody who's interested, we can talk more afterwards about training and outcomes that the research provides this time. Historically, as many of you probably know, frenotomies were performed routinely. Any baby who had a tongue tie had it placed. In the early 20th century, there were research studies that came out that failed to demonstrate a link between speech problems and ankyloglossia. So frenotomy sort of fell out of favor. And it's also, at this time, coincided with the introduction of infant formulas, and breastfeeding rates started to decline. So there were fewer issues in the end of the 20th century, mid-end of 20th century, as breastfeeding rates have started to steadily rise. The increased interest in this topic, and in the last few years, there have been some randomized controlled trials that have demonstrated that frenotomy improves breastfeeding problems. How common is it? Most of the studies quote, between 2 and 5% of infants have a lingual frenulum. Of these, somewhere between 25 and 40% will have breastfeeding problems. There is a well-established male predominance with a 3-to-1 ratio. To define ankyloglossia, it is a condition in which the function and movement of the tongue is compromised due to a structural restriction. And I think the key is that the function and movement of the tongue is compromised. So there have been some classification attempts to better quantify how severe a tongue tie might be. I came across the classification system that looked at the length of the tongue to the frenulum, or the which correlates with the extent of the movement of the tongue. Normal tongues having 16 millimeters or more of tongue movement, with decreasing lengths, with a complete tongue tie having only 0 to 4 millimeters. Most research that I came across, and what I have found most helpful that Dr. Mayer presented, was this classification system, which really distinguishes between anterior and posterior tongue ties. Anterior tongue ties being the most common, which account for 92% of cases. Types 1 through 3, account for 92% of cases. Types 1 and 2, which are the most common, account for 75%. The posterior tongue tie, type 4, which is much less common, accounts for only 8% of cases, and this type actually has a female predominance. I'll show you some more pictures. This is an example of a type 1 ankyloglossia. Frenulum starts at the tip of the tongue and goes to the floor of the mouth, and you'll classically see this heart-shaped appearance of the tongue, the scalloping of the tongue. You probably have seen these in your practice. 2, the frenulum starts 2 to 4 millimeters from the tip of the tongue, extends to the lower alveolar ridge, and then down to the floor of the mouth. This type, what we see in examination, is that there's significantly restricted elevation of the tongue and extension of the tongue. 3 is less common and a little bit harder to detect. It's a detachment. The frenulum starts at the midsection of the tongue and extends to the floor of the mouth. The top picture, what that's demonstrating is that some of those babies, you'll see that the sides of the tongue sort of cup. The whole tongue is not able to lift. So you see the edges kind of curling up because there's restriction at the base of the tongue. Type 4, your posterior tongue tie. I think I've maybe seen one case of this, but I'm not 100% sure if it actually was. But it's very hard to diagnose. It's very uncommon. But the attachment can be submucosal. The frenulum occurs at the junction where the underside of the tongue meets the floor of the mouth. So you don't necessarily see the frenulum as easily, but what you do see is then that restricted elevation and extension of the tongue. So is it a problem? There are many people who live with tongue ties, and I think there are many cases where it doesn't necessarily pose a problem, and obviously the severity of the tongue tie may impact what problems it may or may not lead to. The top of the slide are the less controversial problems that have been well established. If the frenulum is attached close enough to the end of the alveolar ridge, there'll be duration of the central incisors. Especially in type 4, they have difficulty manipulating boluses of food, which can also lead to food particles getting trapped. And because the tongue is not able to lateralize. It can't sweep the teeth to clean the mouth properly, so they have increased risk of dental caries and choking. Social problems can occur. It's hard to lick an ice cream cone. They may have trouble kissing. An author actually quoted that some children during adolescence actually get teased because of their anomaly, and it could potentially affect their self-esteem. There is a lot of evidence now that, in the medical literature, that it's now widely accepted that Ankyloglossia does not cause speech problems. Where there's still controversy is that in some severe cases, there may be some articulation issues. I actually had a father of a baby who also had a tongue tie, and the father had a tongue tie that hadn't been licensed. He was a professional singer, and his voice coach suggested that he get his tongue snipped, and he felt that actually really improved his singing and his ability to articulate sounds better. But the main issue, and really the main indication to consider frenotomy, is breastfeeding problems. So in this illustration, you can see in the top image the normal tongue position, so that the tongue is able to extend past the alveolar ridge, so they're able to get more of the tissue, more of the areola into the baby's mouth. The nipple can get towards the back of the mouth, and the peristalsis of the tongue allows good compression of the sinuses of the milk ducts, which allows adequate milk retrieval. Turns out that I think the simplified the lactation consultants can probably explain better some of that physiology, but you can see nicely in this cartoon how that's able to function. Where in the tongue tie, the tongue is not able to get past the alveolar ridge, the nipple is not able to get far enough into the baby's mouth and compress the sinuses. The baby is just latching on to the very end of the nipple. Often describe that they feel like the baby is biting them, and obviously this can cause significant nipple pain, soreness, cracking, bleeding, difficulty latching, which then can cause poor milk transfer. If there's inadequate milk retrieval, you get stasis of milk, clogged ducts, mastitis, suppressed lactation, and untimely weaning. So what's the big deal about nipple pain? It really bad? Can't they tough it out? Doesn't it get better over time? It can't usually be toughed out. These are a couple of examples of severe cracking, infection of the breast. But for anyone in the room who has never breastfed, so any men, but not to pick on men, and any women who may not have breastfed or had any problems breastfeeding, if you imagine taking razor blades to your nipples for about 20 minutes, do that on each side, and then do that every 2 to 3 hours, 10 to 12 times a day. How long do you think you could last? 1 day is an eternity. So it's extremely painful for these women, and it's just not sustainable. So there's nipple pain and there's nipple pain. So ways to kind of distinguish when you're talking to the mother what's normal and what's not. So in the first couple of weeks, there can be some discomfort and some pain that mothers describe. Discomfort should go away within the first 30 to 60 seconds. So if the pain doesn't subside in those first few seconds and it's painful throughout the duration of the feeding, that's a problem. That's not a good latch. Generally, some of the initial soreness that is in the first couple of weeks should go away within 2 weeks age, and there shouldn't be any excoriations, bleeding, cracking of the nipples. Whereas the pathologic nipple pain, the pain is lasting throughout the feeding. It continues beyond 2 weeks and may not have bruising. The problems that it can pose for the infants, as we talked about, inability to latch onto the breast. Mothers might also describe that the baby slips off the breast because they can't achieve a proper latch. They might describe clicking sounds, and that's the tongue kind of coming off the breast again. This baby, because they may not be getting adequate milk retrieval, is constantly hungry. It's the baby who's feeding every hour, every half hour, crying, may lose weight, may see breastfeeding jaundice, and in some cases, failure to thrive. So what's the evidence? So the first kind of good large study that was done was by Dr. Ballard, Jeannie Ballard, in 2002. This was, they collected data between January 1998 and June 2001 at Cincinnati Children's Hospital. They assessed inpatients in the well-being nursery as well as at their outpatient lactation clinic, and determined which phase had significant tongue ties based on a rating scale called the Hazel-Baker, which I'll review briefly. And they assessed the mother-baby pair for breastfeeding problems, latch problems, nipple pain, and those who had both Ankyloglossia and breastfeeding problems were offered enrollment in the study to have a frenotomy performed. Of the 2,100 inpatients, 88 were found to have clinically significant tongue tie, or 3.2% incidence. 56 of them presented with a poor latch, 32 with nipple pain. In the outpatient setting, 35 had clinical tongue tie, a little bit of a higher incidence. These are infants who are having more trouble breastfeeding at this point, hence their referral to the clinic. 12.8% incidence. 14 had a poor latch, 21 had nipple pain, failure to thrive, 4 with recurrent cystitis, and 4 with suppressed lactation. So in total, there were 127 infants that met criteria who were offered frenotomy. 4 declined. The remaining 123 underwent frenotomy. After the procedure, before the procedure, mothers rated their pain on a scale from 1 to 10, and then after the procedure, they rated the pain again, and the lactation consultants and the pediatrician were assessing the quality of the latch both before and after. They made telephone contact 3 days later, as they originally do, and there were no complications related to the procedure. So the Hazel-Baker assessment tool for lingual frenulum function, it's a mouthful, is the most standardized way to quantify and assess the frenulum function that was used in really the majority of the research studies. This tool did undergo validity in 1993, but only more recently rater reliability was established on all of the appearance items and the first 3 function items. So it includes scoring between 0 and 2, and there's descriptions of each of these things. 5 appearance items of the tongue, appearance of the tongue when lifted, elasticity, length of the frenulum, attachment to the tongue, and attachment to the alveolar ridge, and 7 functional items. And they reliably found that if infant scores a function score of less than 11, that is generally considered a good indication for frenotomy. That was what they used for their inclusion criteria. So in Ballard's study, they found a slightly lower male-female ratio, 1.5 to 1. They did find a strong family history in 26 of the infants, a 21%. What was interesting was that the infants that presented earlier presented with a poor latch, and infants that presented a little bit later presented with nipple pain, which seems sort of obvious how that evolved. And there was a statistically significant difference with the infants presenting with poor latch at 1.2 days versus 2 days for the ones presenting with nipple pain, and this demonstrates those findings. So initially it's latch issues, and then if the latch issues continue, then you get pain. They showed a statistically significant nipple pain, pre-frenotomy 6.9 down to 1.2. This was all of the subjects. Now, they don't have a control group in this study, so that's kind of one of the potential shortcomings, but we'll get to some other studies. They did show that 123 of the 123 had improvement in their latch, or 100%. 31 of the 35 outpatient mothers were breastfeeding more comfortably after the procedure. 3 patients stopped breastfeeding despite the procedure. A mother of one of the failure to thrive babies, who was 4.5 months old at the time, was advised to feed formula. But the remaining 5 infants with failure to thrive resumed breastfeeding and achieved normal growth within 3 to 5 days after the procedure, which I thought was pretty interesting, significant. So Dr. Hogan in 2005 performed the first randomized controlled trial, dividing the subjects into immediate frenotomy versus 48 hours of intensive lactation. And in this study, they identified 201 infants with Ankyloglossia. Of those, 88 had breastfeeding problems. 7 were enrolled and were randomized. They had 29 controls and 28 who had immediate division. Of the 29 controls, only 1 improved with 48 hours of intensive consultation. Of 28 with immediate division, 27 of them improved, with 1 remaining on a nipple shield, and this was statistically significant. After 48 hours, if the lactation support failed to improve the problem, they were offered frenotomy, and 27 of the 29 controls chose to proceed with the procedure, and overall 54 out of 57 of the infants had improved feeding, or 95% success. The last study that I want to cover in 2011 was the first single-blinded randomized controlled trial, which seems interesting to me. How do you blind a procedure? But in this study, they had a very captive audience. It was on a naval base in Virginia over a 12-month period. They enrolled infants who had significant Ankyloglossia as determined by the Hazel-Baker, plus either pain or breastfeeding difficulty. The enrolled infants were randomized to either frenotomy or a sham procedure. So what they did was the baby was seen by an ENT, and at the appointment, the infant was taken to a procedure room away from the mother. Frenotomy was performed, or they did nothing, but over the same amount of time as it took to do a frenotomy, returned the baby to the mother. The mother was carefully instructed not to look in the baby's mouth until after the feeding. They gave the baby directly to the mother to breastfeed immediately, and then they assessed right after. And in this study, their goal was, again, to try to determine whether or not frenotomy improves nipple pain and the ability to breastfeed. And the other question that was still yet to be answered is whether frenotomy improves the length of breastfeeding. Most of the studies are able to assess the immediate improvement in nipple pain right after, but are these women continuing to breastfeed? So as I sort of explained, so their methods were to first identify mothers who were having nipple pain who were referred to the lactation team, and if those infants were noted to have ankyloglossia and the nipple pain or breastfeeding difficulty, they were enrolled, and they used more of the standardized assessments than the previous studies had used. So they used the Hazel-Baker for lingual function, and they used the short-form McGill pain questionnaire to rate mother's pain, and an infant breastfeeding assessment tool, which has been to have validity and reliability at assessing breastfeeding. So those infants were randomized. Of note, just before the frenotomy or sham procedure, the ENT who was doing the procedure did his or her own Hazel-Baker right before to assess, and they did find actually 100% agreement between the lactation consultant's Hazel-Baker results and the ENT results right before the procedure. And then, as I mentioned, they returned the baby to the mother and repeated all of these scales again. So what they found, of over 3,000 newborns that they evaluated, 58 met criteria, or 1.9% incidence, as we mentioned earlier in the talk. For those who missed, has been reported between 2 and 5% incidence of tongue tie. It's not clear if that number might be higher, because for some infants or some people who don't have any issues with it, they may not come to medical attention, or and in this study, they were only brought to the attention of the investigators if they had nipple pain. So for those who might have had tongue tie without, but breastfeeding fine, they didn't get into the study. So those, enrollment was at a mean age of 6 days. 28 were in the sham group, 30 were in the frenotomy group. These subjects refused enrollment. And some point, and they don't really say exactly when, but at some point before the 2-week follow-up, which they did, those who were in the sham procedure were allowed to proceed with a frenotomy if they wanted, for ethical reasons as determined by the IRB. So all but parent in the sham group elected to have the frenotomy, and there were no complications from the procedure. So this shows you the results of the short-form McGill pain questionnaire, so the pain ratings by the mother. So as you can see, the frenotomy group, pre and post, there was statistically significant decrease in pain scores. There was actually, this actually did show statistically significant decreases in pain scores in both groups. So there may be a little bit of placebo effect. However, the frenotomy group improved significantly more than the sham group, and that had a p-value of less than 0.001. Okay. And in the infant breastfeeding assessment tool, pre and post, there was significant improvement in breastfeeding in the frenotomy group, top curve, as compared to the sham group. Now, unfortunately, by the 2-week follow-up, almost all of the sham group underwent frenotomy, so they lost their control group at that point, and basically their scores all started to match or approach the same as the infants who had the frenotomy done immediately. They did follow these infants a little farther out, as they had hoped to get more long-term data, but again, without having lost the control group, there was no significant difference in breastfeeding rates between the two groups at 2, 6, and 12 months, with 66% still breastfeeding at 2 months, 44% at 6 months, and 28% at 12 months. Over time, though, mothers continued to report decreased scores and improved breastfeeding until after 2 months of age, where things sort of leveled out and there was no significant change in scores after that. how to tell who might benefit from frenotomy. So in the assessment, in addition to the history from the mother of any pain or difficulties with a latch, visual inspection, look for that heart-shaped scalloping of the tongue. You can, sometimes it's obvious, you can see the tongue. What I do routinely with all my newborn exams is a sweep with a gloved finger, or you can use a Q-tip, but if you sweep under the tongue, if it catches, there's a tie. And some, you know, again, more obvious than others, but that's a good tool. Tongue to see what the frenulum looks like, also by seeing whether the tongue elevates, that should elevate past kind of the mid part of the mouth, and then assess the oral motor. And this is also, I find, easiest to do by letting the baby suckle on a finger. You can feel the tongue protrude past the alveolar ridge on your finger. If it doesn't, you feel the gum line banging up against your finger. That can be helpful. And tongue cupping, sort of gotten the hang of this over the last few years now to be able to tell kind of when the tongue is actually cupping the finger completely, or if it's just cupping on the sides but not in the front of the tongue where the frenulum is attached. So the AAP, you know, recommends that infants breastfeed up to a year of life and beyond, as long as it's mutually desirable by mother and baby. And so we as pediatricians are charged with the task of trying to encourage these mothers to continue breastfeeding. When there are problems, if there is a significant tongue tie, the Academy of Breastfeeding Medicine states that primary care physicians may consider performing the procedure in babies who are under 4 months of age, anterior tongue tie, who have a translucent frenulum. So those type 1 or type 2 ankyloglossias, where it's a nice thin translucent membrane, type 3s and 4s I don't touch, or even if it's not a straightforward type 1 or type 2, I refer those to ENT. What allows us as primary care doctors to do this, since we're not surgeons, is that we're not doing any repair. It's just cutting without repair, so it's a frenotomy as opposed to a frenuloplasty, which is what they do in some of the older infants, also known as frenulotomy. So to do the procedure, it's pretty simple. You need two things, a grooved director or a grooved retractor, which is, they say that it can sometimes be found in circumcision kits, but I've never seen one in a circumcision kit. I don't know if the OBs, but it can be ordered easily, and an iris scissors. Some people use a technique of using their fingers behind the tongue. I don't trust that I won't cut my finger, so I prefer using the grooved retractor. An assistant to stabilize the mandible. The nurse usually helps to hold the baby and stabilize the mandible, while the parent actually holds the baby's arms and legs down, or whichever parent feels comfortable doing that. If they don't feel comfortable, another nurse can do that. Some providers use swaddling the baby. I prefer having the parent there. They usually at least one of them likes to kind of watch and see what's going on. It's thought that the lingual frenulum actually has virtually no nerve or blood supply, very little, so there's really minimal bleeding and minimal pain. They're most upset because we're holding them down and holding their jaw down. There's a technique of using a hemostat to clamp frenulum at the location where you're going to cut it, which kind of the tissue, but to do that you need to use viscous lidocaine because it's painful. But they report less bleeding because of the hemostasis. There's virtually no bleeding. There's usually a few drops that you can get up the gauze. I always have silver nitrate on hand. I've never needed to use it. And the mouth, as we know, heals so quickly, and then we have the baby breastfeed immediately afterwards, which accomplishes several goals. One, it comforts the baby and comforts the mother, and two, the antibodies in the breast milk helps reduce risk of infection, and three, it also allows you to reassess the function. And the other potential problem is just if lidocaine is used, then it's numbing and the baby can't breastfeed right afterwards. You have to wait like 45 minutes to reassess breastfeeding. And this is always discussed with the parents beforehand, obviously. I mean, the list is pretty short: bleeding, infection. There can potentially be a portion of the genioglossus muscle in the lingual frenulum. So I always mention that we look for that if I see anything. I mean, I've never seen it, but if I see anything that looks like there may be some pink tissue in there, I don't cut those. We refer those, but there's a potential risk. More commonly, when described issues with the muscle is in frenuloplasties that are done by the ENTs in the older infants. So, courtesy of the experts in the field, I was able to get this video to show you of the frenotomy. There's no sound, but cool. Hope it works. Okay. So you can see someone is stabilizing the mandible. The retractor goes around the frenulum, and avascular portion of the frenulum is snipped. Usually it takes one, maybe two snips, a little bit of bleeding, top it up with the gauze, and that's it. When I first started doing them, I made the mistake, or not the mistake, but I had a tendency to cut, not because afraid to go too far. With experience, I'm going a little bit deeper, and times will be in one snip. I usually check right afterwards to see if I've completely freed up the tongue. If there's still a little bit of frenulum, I can go back and snip again. And what I also tell parents is that if you happen to hit the floor of the mouth, some of those will heal with a little white patch, a little granulation tissue. So I tell them that if they may see a white patch, that's normal, not to worry, and usually do a follow-up 4 days later.
Question.
So, yeah.
So Nat, do you have a preference closer to the tongue snip?
Good
or
question.
Closer to
Thank
the
you.
body?
Yeah, thanks. So the retractor should be vertical behind the tongue, and the cut should be as close to the groove tractor as possible, straight up and down. So you want to be actually closer to the tongue and not closer to the floor of the mouth. So holding the tongue up with a retractor, and your scissors is going right next to it. Okay, so.
Well, on that kid didn't look so bad. I mean, it didn't look like his tongue was really
right.
in.
Well, it wasn't a type 1 Ankyloglossia, which is the ones that are really the most obvious, that are pinned to the tip of the tongue. That was probably a type 2 Ankyloglossia, where the attachment is 4 millimeters from the tip. I don't know the details of that case, but sometimes it can be to tell unless you assess the function of the tongue, and that mother maybe, I assume, was having difficulty breastfeeding, nipple pain, or trouble with the latching. But again, some of the tongue ties, if it's, I don't know if you all saw the different types at the beginning, but uh-oh.
You didn't have a lot of follow-up. What percentage of those type 2s would stretch, where the frenulum would eventually stretch? Right.
So we don't have that data yet. So we don't have the long-term follow-up, which is the ultimate question. The immediate concern is that if that mother-baby pair is trying to breastfeed and mother has such severe nipple pain that she can't continue breastfeeding, she may stop breastfeeding. So it's really the only indication for the frenotomy would be if there are breastfeeding problems. If they're having no trouble breastfeeding, then a lot of them, can stretch over time, but it's not going to fix the breastfeeding problem that's happening now. So it's really more of a needle issue. Is there a breastfeeding problem? If not, you leave them be. You follow closely to see if mother's feeding well, if the baby's gaining weight, mother has no nipple pain, they're doing great. There's no need to do anything, in my opinion, from what I've read. So it's really a question of, is there a breastfeeding problem? And if there is, then cutting the tongue tie can improve breastfeeding and hopefully prolong their breastfeeding. But in all of the studies, because all of the infants who were having trouble or there was nipple pain, they didn't last weeks without wanting to undergo the procedure to try to improve the breastfeeding issue.
The question is, I don't understand what breastfeeding would do immediately afterwards in terms of fighting infection.
The antibodies, help.
I don't want to be, I think it hurts, but I don't think it's going to do it.
The antibodies in the breast milk, the mouth, and it's fast, but
antibodies are going to bathe in the mouth.
There'll be triage.
Like to see the study.
Triage is local, so
yeah, right. Sure.
Yeah, and Alex usually doesn't use it either, so.
Circumcision.
And in none of the studies did they show that there was ever, that any of the babies got infections. So I think it's a theoretical risk more than it is an actual risk.
Infants latch onto a bottle more easily if they were, and then no need for an alternative. How does that? Well,
if they oftentimes can latch onto a bottle, but then they're not breastfeeding. So, but
if mother elected to, then you could save this procedure, right?
It's a risk-benefit ratio, so it's a relative. There are relatively no complications for a procedure. If you want that baby to continue breastfeeding, that's preferable than having them switch to formula. Yeah.
Right. That underestimated is actually double, it's actually 4%.
Right.
Which would mean you get 4 babies for every 4 with this for every 100 babies.
Right.
Right. How many procedures? The second question is, how many babies do we get from the nursery who are told that they have this, and it's a higher percentage than 4%? And that's my biggest problem.
Right.
But it seems to be almost everybody coming in saying that they're anyone breastfeeding that they have.
Right. I do have the experience of a lot of parents coming after having met with people outside and saying, they wanted me to have the baby checked because they think they have a tongue tie, and, or a lip tie, and I tell them I don't that they do, and I don't think that's your problem. And I did try to find out from our coding people how many I've done. In 3 years, I've done 25. It was roughly in 10 years, maybe a year, so maybe 1 a month, but or a little less than that. But there have been many more infants that either had a non-clinically significant tongue tie or wasn't breastfeeding that I told them you don't need to do this. So I'm not snipping them unless there is significant breastfeeding problems, and primarily it's nipple pain, and mothers come in saying I can't keep doing this. They're in tears, they're crying because it's so painful.
We can have people not tell people in the nursery that they're tongue tied.
I
find that
right.
the truth is there's a bias there. They're already thinking there's going to be a problem with my child tongue tied.
Right.
And they come in, they're gaining weight fine, and they're worried that perhaps they're tongue tied. They need to do something.
Right. I think what's really helpful, and I think what's done most of the time, correct me if I'm wrong, is that, I mean, I know sometimes the parents are told. I think ideally, if a lactation consultant, a nurse, thinks that you tongue tie when they see a baby, is tell the pediatrician, and then and we're going to be following that baby after they go home to also determine if pain becomes an issue or if they're having trouble gaining weight, and be able to determine if that baby actually needs anything done. And in some cases, depending on the parents and the mother, you know, telling them that there's a tongue tie, you know, is impact, you know, or telling them that it's tongue tie and if there's no functional issue, can then have a placebo effect, you know, and so I agree with you, and I think that we do to be selective about, you know, when we assess it, and there are sometimes babies in the nursery on the first day where I see it, but I don't say anything yet because I want to see what happens with the breastfeeding, or at the time of discharge, we might, you know, if it seems fairly obvious, we might discuss it, but I say, you know, many babies can breastfeed, and it doesn't pose a problem. Let's see how this goes and reassess. And again, it's really exclusively when there's significant pathologic nipple pain or problem with weight gain that then it seems like there's risk and a lot of potential gain in those cases. But it's checking those cases and determining when it seems appropriate to offer it that's important. The recent case that I had, this is a 4-day-old newborn, born at 38 weeks by normal vaginal delivery, born to a 35-year-old G1P0 mom. There was Ankyloglossia noted in the well baby nursery. This was at the first newborn visit. Birth weight was 7 pounds 3 ounces. Discharged at 2 days old at 6 pounds 13 ounces, or a 5% decrease in weight. The pain for the mother was persisting throughout the feeding. The mother was telling me that she was feeling extremely discouraged. She couldn't tolerate more than 15 minutes at the breast. It was excruciating, and they had started supplementing with formula because her milk wasn't coming in yet, but she also just couldn't tolerate the duration of the time that the baby needed to feed. The baby was crying, hungry. The baby did gain weight at this initial visit, so the weight at 4 days was 7 pounds 2 ounces, so there was adequate weight gain, but the mother was really motivated to breastfeed, and she was, you know, very upset that it was causing such pain. This was back for a second. So this is what his tongue looked like. Anyone want to say what type of tongue tie it is? So type 1. So you've got that heart scalloping. It's the lingual frenulum is attached to the tip of the tongue. I'm going to skip this video. That was one. This is the tongue right after the frenotomy. And at 8 days old, the nipple pain was significantly improved. By 8 days, the mother was now breastfeeding near exclusively. The formula supplementation was down to 2 to 4 ounces per day. The baby had even in weight, an increase of 8 ounces in 4 days. Unfortunately, for this she had to go on medications that precluded her from breastfeeding. So again, and I'm interested to know kind of the long-term follow-up on this, if this is making a difference long-term or not. And I think that's the question that remains unanswered. I'm convinced that in the immediate period, newborn period, establishing breastfeeding, that there is a benefit, and the data support that. Someone who's interested in learning how to do the procedure or doing the procedure in their office, these are the codes for it. Ankyloglossia occurs in about 2 to 5% of newborns. Of these, 25 to 40% may present with difficulty breastfeeding. Primarily, they present with nipple pain and poor latch. It's probably genetic. Oftentimes, if you look at the mother or the father, usually the father's tongue has a tongue tie too. Frentomy has minimal risk. There's about 95% effective according to the studies that have been done in improving nipple pain and breastfeeding. And again, this is immediately afterwards. Some limitations on the methodology of studies. Some studies are, don't have standardized rating, are not using the standardized rating scales. There's still not good standardized ways to assess these infants, although the Hazel-Baker, I think, is a little closer. We need more long-term data. The difficulty is that, can one do a randomized trial long-term and not perform a frenotomy if a baby is continuing to have breastfeeding problems? The IRB doesn't feel that's ethical. So I'm not sure how the study can be done. They'd be able to get out to 4 weeks or so, but again, that's tricky. References. And just hoping for summer.
Yeah, for those moms who have nipple pain, have arthritis, go for procedure, the mom goes to the parents what in the world of the lactation, point of view over this area.
Parents don't choose just working with them for latch. The thing is, when a baby doesn't latch deeply, they don't move as much focus in the beginning, and then they don't establish their multiple lives. So we have to watch for weight gain, failure to thrive. Babies, like the baby that gained weight was having formula, and that's probably why they gained weight.
Right.
But it's just that what we need to do is try and get the latch with that and watch the weight and the output. Things were not going well, and chose not to have
The nipple pain is the problem.